and I welcome you to our next to the last presentation of the day. You've reached yet another session of our annual summit where the theme providers and purchasers partnering for quality rings loud and clear. For primary care physicians and internists in the audience, a patient-centered medical home is a concept that's dominated many of your state and regional conferences over the past 6 months. However, we have not seen as much activity taking place in the multi-stakeholder group, such as the ones represented at this conference today. The Business and Health Coalition wanted to change that by teeing up the conversation at our joint summit with VBCH. We wanted you to hear from a multi-stakeholder group in an interactive panel format to identify the what Virginia is doing to gain traction on patient-centered medical home and other primary care improvement areas. We know that we cannot cover everything in 45 minutes, so we also wanted you to take away a very useful publication, the Patient-Centered Medical Home, a Purchaser's Guide, which you all found at your places early this morning at the conference, prepared by Michael Baylett. This will allow you to sit back and enjoy the presentation this afternoon without taking notes or following a PowerPoint presentation. The why of the subject is obvious. We've heard it several times today. Our fragmented American healthcare system leads to overuse of expensive services, underuse of information technology, and an overall lack of coordinated care. As a result, our nation spends twice as much on health care as any other country and gets results that in many cases are far worse. I will serve as the moderator and the timekeeper, and we've asked each panelist to spend 4 minutes on their respective area of experience on the topic. We were intent on informing you on what is happening in Virginia, and you will hear the role of the physician and the nurse, the role of the purchaser, the role of the consumer, and the role of the health plan, and a best practice example in Virginia, patient-centered medical home. Following these discussions, we will allow 10 to 15 minutes for our audience Q&A. Now it's my pleasure to introduce each of our 6 panelists in order of their presentation. You'll also find brief bios in your program folder. Our panel is diverse and representative of all the unique partners necessary to address improvements in primary care: the clinicians, the insurers, the purchasers, employers, and the consumers. Also, these individuals represent different geographic locations around the state and each have a unique knowledge of some of the potential strategies and steps that can be taken to move this initiative forward in Virginia. To my right is Anton Kuzel. Dr. Tony Kuzel is chair of the Department of Family Medicine at VCU Health System MCV campus in Richmond. He'll provide an overview for us of the patient-centered medical home and also from the provider perspective, some practical strategies for creating a patient-centered medical home. Our second speaker is Dr. Peter Anderson. Peter's been practicing medicine for 25 years and is associated with the Hilton Family Practice in Newport News, and recently learned he is the first physician in Virginia recognized by the National Committee for Quality Assurance Recognition Standards for Primary Care Practices. That's titled PPC-PCMH, Physician Practice Connections, Patient-Centered Medical Home Standards. He will speak on from the provider perspective, titled "It Can Be Done: Increase Practice Capacity and Improve Quality." He will be followed by Teresa Huddleston, who's a nurse with Fairfax Family Practice in Fairfax, Virginia. She'll speak about the nurse perspective and the team approach to family care. Our fourth speaker is Colette Edwards. Dr. Edwards is VP and Senior Market Medical Executive with Cigna Healthcare Mid-Atlantic. She's also the National Medical Executive for Health Disparities. Dr. Edwards will speak about the role of the health plan in improving patient care. Fifth speaker is Kurt Elward. Dr. Elward is Medical Director of the To Go program, which is in a program affiliated with the Medical Society of Virginia Foundation. Dr. Elward will speak from the provider perspective and address the program To Go, a best practice example in Virginia. Finally, Victoria Lucente will be the sixth speaker. She's Assistant Superintendent for Budget and Finance for Chesapeake Public Schools. She will speak from the purchaser perspective, the role of purchasers and consumers in improving care. I met Dr. Kuzel last year at this meeting. It's just been a year, but we've had some meaningful conversations, and he was very instrumental in helping to plan the panel, and I want to thank him for the great leadership that he's provided to me and to the coalition this past year. And Dr. Kuzel will be the first up to provide an overview for the patient-centered medical home. Tony?
Thank you. I'm going to stay seated. I think many of you already know this, but this concept of patient-centered medical home was first put out as a term by pediatrics, I think back as far as the 1960s. And in recent years, it's sort of come back and has been embraced by multiple specialty organizations in primary care, both allopathic and osteopathic. And what I want to quickly move to is what everybody agrees are the important principles of a patient-centered medical home. These are the organizations that have signed on to this list of principles, and here they are. You can read them as well as I could speak them, because I want to get into what we want to share with you today and have you hear the other people on the panel. But I'm going to leave this slide up so that you can be reflecting on, are we talking to these principles? Are we helping to move practices towards this ideal model? As chair of family medicine at VCU, I wouldn't choose any other specialty, but I recognize that many medical students these days are not choosing family medicine, and I think most of you know why that's happening. I was faced with, do we wait until there is significant healthcare reform in the United States, or do we figure out a way of doing things better that leads to more effective, efficient practices that are in turn far more viable choices for students from our schools to be making. And I decided that was the better course to take, and not to wait around for other people to fix things. As I started to look around, I found models of primary care practices that were doing a fabulous job. Some of the people on this panel are represented by, represent that, and you're going to hear their stories. And as I looked at those, I thought, I think I can see a way for people to go from their ordinary practice, which is really honestly mediocre practice in many ways, and without special financing, achieve a patient-centered medical home. And I'd like to share with you some of the steps that I think are possible. The first one is for, and I'm going to speak from family medicine's perspective because it's the data that I know the best. Family medicine docs, by and large, do only a middling job of documentation, and they do a pretty lousy job of coding, either because they don't know or they're scared of audit. And if you look at the distribution of codes in a typical office compared to the work that actually happens in those offices, and if you assume Medicare payment rates, the typical family physician in the United States is leaving about $50,000 on the table by underdocumenting and undercoding. So if you stop doing that and you get that resource in, the next thing that you do is, it would be tempting to increase your salary, but really what you want to do is to hire more staff. Part of what makes it difficult for FPs is that they are doing things that they didn't go to medical school to do. And if you have more staff who can do things more effectively, efficiently, and at lower cost than you do, then hire those staff and have everybody working to the top of their license. That's the most fulfilling thing for anybody in an office, is to work to the top of their abilities. Docs should be doing that, nurses should be doing that, the other staff should be doing that. When you've achieved that kind of team care, and you're going to hear more details about that, at that point you should be looking at how you're scheduling, and you would implement advanced access scheduling. A few years ago, before we did it in my office, it was 3 months to get in to see me for a routine appointment. Now it's between 3 and 6 days. I actually have a larger panel than I did back then. It has to do with different models of scheduling. When you are starting to really hum and you can feel the efficiencies of your office, it's at that time that you say, well, I've been seeing 20 a day or 25 a day, whatever it is. I now actually feel like I have the breathing space where I could see more patients and or have a larger panel. Depends on the payment model. but in most communities in the United States, it's still fee-for-service. So that would mean that to get more income, you have to increase your volume in the office. And I won't debate, whether that's good or bad. It just is. This is the cards that we currently have to play with. And if you add 5 patients a day for the typical family physician Medicare payment rates, you're going to add about $70,000 to your income, maybe $80,000 to your income. Very significant. If you're making that kind of money and you're in a group practice, I think at that point you think about expanding your hours, and you go from, instead of a 9 to 5 practice, to some evenings and weekends. If you have that kind of a practice, you're going to reduce ER utilization, but you're also going to have very grateful patients to have access to you when it's not during regular business hours, when they're working or when their kids are in school. If you have that kind of an income stream, it's at that point that you'd want to take the risk of buying an EMR. They are expensive. They are going to slow you down. I think you wait until you have a very highly functional paper-based team care before you get the EMR. Up to this point, you've been doing really good one at a time quality work because you've got a team doing it instead of it all being just the doc having to remember to do things. You now have a systematic approach. When you have an EMR with a registry, you can then look at population care and say, okay, I think I'm doing pretty well with my diabetics, but let's take a look at all the A1Cs in my practice, etc. Then when you have the EMR and you're doing this good population work, you can be thinking about getting a portal. Allow your patients to get access to you besides having to pick up the phone. And there's a variety of functions that can go along with that are very patient-friendly and practice-friendly. If you are in a place like Peter is at, where you have a common information platform, you're already ready to integrate with other providers in your community. If that doesn't exist, then maybe you have a regional health information exchange, such as Med Virginia here in the Richmond area. But find some way to link with other providers, because you need to know what's happening with your patient panel at all sites of care if you're going to really be the coordinator of care. And the last piece would be to collaborate with others to figure out how you can work with them to reduce the spend on the 5% of patients in your practice that account for 50% of the costs for a given plan. And that holds true across any kinds of payers. And what I see as key enablers in this would be obviously, one, overcoming the obstacles to documentation and coding that obviously are out there. I mean, family docs know that they can and should be doing better, and they don't do it. So there's still that obstacle that has to be taken care of. I think the office culture is hugely important. We've heard about this several times today. People or offices that get relationships right across a variety of domains are more likely to be able to pull this off. I think getting the support from payers and purchasers to let this happen, because if you do what I'm suggesting, your primary care spend is going to go from 5% of the healthcare dollar to maybe 6 or 7%. And I believe that even if it does that, you're going to see neutral or reduced overall costs of care, but we need to be able to demonstrate that that's true. And I think the last piece is creating communities of practice so that providers in a region continually learn from one another and help one another solve the practical issues that keep them from hitting these ideals. So with that, I'll stop and allow Peter to tell his story. Sure.
I better stand up. This one? Tony did an excellent job. I was laughing a little bit. How can he present this model in 4 minutes? It's hard to understand after an hour. I fit into this model, but why has the patient-centered medical home gotten so much traction? Because you go anywhere on a national basis, and that's all you hear about is patient-centered medical home. I think it's sticking with employers, the government, with academic medicine. All the medical schools are talking about it. And my peers, like the American Academy of Family Medicine, American Academy of Pediatrics, and the American College of Physicians, are all basing their future on this model. I think there are 2 reasons why I say it's sticking. First, it meets the healthcare needs of the individual. It's not dropping half of needs. It does meet adequately and completely the healthcare needs of the patient. And it's built around the doctor-patient relationship. In other words, it delivers excellent care in a personal manner. And we really want both. We don't want just excellent care, and we just don't want personal touch. We want both, and the patient-centered medical home can do that. But a good visual and imagining of this transition from our typical family practice office to the patient-centered medical home is imagine replacing a pickup truck with an 18-wheeler. That's what we're doing. You're taking a small capacity machine and replacing it with something with a lot more ability. And it's not easy transition. The 18-wheeler has a lot more capacity, but you need a lot stronger motor to drive that truck than you did for the pickup truck. And that's where family team care comes in. The model of team care that Tony mentioned is a doctor working with a team of nurses to deliver the health care the patient needs. And by doing this efficiently and in enough patients, we become a very strong motor for that 18-wheeler. We're not the whole patient-centered medical home, but without a strong motor, it's hard to imagine how this transition could actually happen. This family team care provides the finances to have both the staff the doctor needs and the technology. You need a very advanced technological system of data and data evaluation to accomplish the responsibilities of the patient-centered medical home. And the family team care model, it can accomplish both the finances and the staff needed, the technology and the staff, because it makes the physician much more efficient in practicing medicine. Under this model, the nurse assistant takes a complete history, does all the documentation of the visit, and implements a treatment plan. Typically things the physician does, but now the nurse assistant does them. While the assistant is doing all this, the physician is free to focus 100% of his or her time on the medical needs of the patient. Not 10 different things, but just focusing entirely upon the medical needs of the patient. And the result of this kind of model, it restores the doctor-patient relationship, which has been greatly fragmented over the last 10 years, to the point patients don't even think they have a primary care doctor because the doctor's not available most of the time. So it restores the doctor-patient relationship, it improves the quality of care delivered, it increases the capacity of the physician to see many more patients in a day than under the traditional model, it increases patient and staff satisfaction, and it increases the financial outcome of the office. This is a statement that I think is very true and accurate. Doctors in primary care today do not need more money, but we need more efficiency. The inefficiency is what's killing us. In the typical primary care office, the delivery of the health care is done today the same way it was done 50 years ago. What business would survive if it hadn't changed in 50 years? So in other words, I think primary care physicians need to become more efficient, not need to be paid more. But what happens is I become more efficient. My income, both personally and for the office, go up dramatically. Now, why would we think the patient-centered medical home would improve costs, overall costs? Well, number one, I can see all the patients that call me the day they call me. No more emergency room visits, no more urgent care visits, no more duplication of services, no more $2,000 workup for chest pain when it really required $100. But another bigger part is the patients start making more rational decisions because they have a relationship with me and I see them every 3 months. They're more likely to take their diabetic medications, their cholesterol, more likely to try to lose weight. Relationships motivate people, and a good doctor-patient relationship is probably the most motivating factor to an individual to improve his health care beyond the own individual's character. The other thing about rational decision, it makes doctors make more rational decisions. And this happened to me yesterday. I have a 75-year-old who's got a lung cancer the size of an orange, and she turned out to have an aneurysm in her chest the size of a cantaloupe. And there's no way that she's probably going to live 3 months. Well, she was presented to the tumor board, and all the specialists said she needed a biopsy. I wouldn't let them do a biopsy on my mother if that was my mother. So I called her up and I said, I'm not crazy about this biopsy. I want to see you. So she lied to the chest surgeon, say, Dr. Anderson, I can't come to your office. But she was too afraid to tell him that Dr. Anderson doesn't want me to have the biopsy. So I saw her in the office and I said, well, realistically speaking, I don't think you're going to be here in 3 months. This aneurysm is going to rupture. It's huge. So I'm not real crazy about wasting any of your time with a possible pneumothorax, possible complication, and end up in the hospital with this needle biopsy. And she liked it, and her sister liked it. Then I called the chest surgeon and said, from my perspective, I'm not real crazy about this biopsy. And he said, that makes good sense to me. If I didn't have a relationship with her, that would have happened. She could have ended up spending 2 weeks in the hospital and wasting the little bit of quality time left. But it all came out of a relationship. And that's what the patient-centered medical home promises, to reestablish the doctor-patient relationship.
A little bit of background from where I'm coming from. From the nursing standpoint, Dr. Anderson's model's done a great deal for our practice. Approximately 3 years ago, we received our EMR system, which is the electronic medical records, and the mood of the office would be quick in, quick out. The nurses would basically just room patients. Very typical office kind of standpoint. After visiting Dr. Anderson in his office, one of our physicians brought back the model that he has for the patient-centered medical home. Presented it to myself, and we started a trial run of it for a good year. After finding out how happy it made our patients, how happy it made me, we then spread it through to the other nurses. So at this point now, we now have 30-some nurses that all are doing the same program, teaching each other how to do it. It doesn't create any more, of a strain on the physician. The nurses teach each other. We have 9 other offices where we have visited and gone and taught them. As a general rule, the way our day goes, instead of just doing vital signs, the nurses now prep ahead of time. We learn the background of the patient by looking at previous notes, looking at their problem lists. We plan out exactly all the chronic care things that need to be done in a day. Any maintenance things that may be preventative that haven't been done that are due, we list them out so that we have an agenda as to what needs to be done when the patient comes in. We take what they're interested in dealing with today, add it to it, and prioritize it. Start as much as we can, do the health physical section of it, giving time for the doctor to come in the room, know exactly what we need to do, what our priorities are, do as much as we can, not miss preventative things. Just really give good patient care while connecting with the patients. The patients feel like my doctor has time for me now. We have a relationship. They don't feel like they're at a fast food joint coming in and going out and just being a number. The nurses, where before there weren't many doctors that knew their nurses' names, now everybody enjoys working together. Everybody knows each other's name. There's a bond between them. Nurses are comfortable with. One of the other speakers had mentioned patient errors and the nurses not wanting to talk to their doctors. Because of this model, the nurses now feel as though they're not working underneath their doctor, but working as a partner with their doctor. So that if they do see something that, I'm not so sure about Mrs. Jones's, lab results, they can talk about it openly, freely, and do, what needs to be done from there without being afraid of who they work for. It's an excellent model, and because of it, not only are our patients happier, and we get to see more patients, and the efficiency is improved, but from a nursing supervisor standpoint, I've managed to keep more nurses now, just from job satisfaction.
And for me personally, can you hear me? No. How about that? Okay. For me personally, medical home is kind of near and dear to my heart because when I first started out in practice, I'm a gastroenterologist. I was in a multi-specialty group practice that was pretty much a setup for the things that you would talk about that you need and would want from a medical home perspective. We actually had our own pharmacy, radiology, and lab, so it was really a one-stop shop setting for the patients, and there was a single chart, although it wasn't computerized, it was a paper chart. And there was also a leadership infrastructure in place that would help support change, workflow re-engineering, and looking at the culture of the group for the greater good of the patient. So very near and dear to my heart. From the standpoint of what the role of the payer should and can be, I can speak to what Cigna is doing currently. First off, we're very supportive of the tenets of the medical home concept, and are actually participating in several medical home pilots across the country, one in New Hampshire with Dartmouth, one in Pennsylvania, one in Vermont, and one in Colorado, and looking seriously at some potential possibilities in the state of Virginia. And kind of generically, I think what the payers have to offer are some resources from the standpoint of data, which may come in the form of information related to gaps in care, clinical programs that we may have that may serve as an extension to a physician's office, additional resources that the employers have purchased for their employees that have value, have benefit, and can really provide additional support and education to members. Also, with regard to changing the dialogue and having the focus change to more clinical dialogue, more focus on prevention, screening, focus on the patient, looking at the patient from a whole person perspective, and then having the employer benefits aligned to support that outlook. And then potentially, depending upon how these pilots go and what they show, changes in reimbursement methodology. We are a founding member of the Patient-Centered Primary Care Collaborative, and the purpose of that group really is it's payers, it's consumer advocacy groups, it's academic medical centers, it's trying to get all the stakeholders together and come up with something rational and strategic so that practices, physicians, hospital systems trying to set up these types of practices don't go crazy in essence. So there's some consistency, there's some standardization, so you aren't having to set up a certain process for Cigna and a different one for United and a different one for Aetna, because that doesn't really serve anybody's benefit and would be extraordinarily expensive and extremely frustrating, and certainly wouldn't get us to where we need to go from a cost and quality perspective. And that's pretty much my summary.
Well, thanks very much for having me. My mother's a realtor in Virginia Beach, so when I talk to her about medical homes, she has a couple of really innovative things to say, like it's, some people like bungalows, some people like cedar shakes. The most important thing is to do a good job of giving you a home that you can call your own. She also talks about location, and part of that goes back to the access that Peter was talking about. But I think a lot of what we've tried to do in our project is create an opportunity for new solutions, just like Peter's, and new opportunities to meet the challenges of chronic care. The Medical Society of Virginia is a 501c3 organization that is committed to improving the health and well-being of patients and helping their physicians provide that care better. And this is an initiative that we developed a few years ago in response to what we've perceived as a great need by physicians to improve their care and give them really tangible tools on how to do it. So my comments are going to be about collaboration, about synchrony, about focused support, and meeting providers where they're at. To goal and now our follow-up project called Impact are what I think are exciting initiatives of the Foundation that provide physicians what they need in the context of what they want or what they need now. That is, we use the required maintenance and certification program to greatly enhance outcomes and promote system redesign. Basically, every few years we have to complete a QI project, and that can be done independently without much support, sort of on your own, and it's a recipe for very, very small improvement, if any at all. And we decided to collect, to allow physicians to come together and collectively improve care and provide them with some support that they need, while learning in the process what kind of support we can continue to provide and what kind of services we can make available. In 2008, we helped almost 100 physicians in the Shenandoah Valley make significant improvements in their cardiovascular care, compared to a group of non-participating physicians, and decreased variation in both NQF and NCQA health improvement parameters by 50%. Not 50% overall, but 50% for each individual item. We accomplished this by linking the required maintenance certification process to group learning, leveraging resources, a web-based support network, and by some focused mentoring. So we took a have-to-do requirement to a high level of enthusiastic, sustainable performance enhancement. We used our mentors and extranet to not only support the participants, but also to learn more about the critical elements of success. There's actually a very clear need to engage and understand and develop primary care performance models, such as the patient-centered medical home, and the leadership for change at the grassroots level. We've learned that primary care physicians can succeed if practical tools are given in the context of system redesign and staff development. As I think Peter alluded to, it's not about me, it's about my practice. And the better I can prepare my practice to give care, the better care I'll be given, and the better my patients will be satisfied. Following along the success of the 2008 model in cardiovascular care, we've taken this to what we call IMPACT, which is improving asthma care and treatment, in which we focus on both pediatric and adult asthma. We've included Centera Medical Group, the Tidewater Physicians Multi-Specialty Group, and the Central Virginia Family Physicians Group as our site, as our number of sites, and have 17 to 18 total practices right now. We've actually had to turn away some applicants because of our funding level. We've also had the pleasure of receiving a check from one of the participants in the original To Goal project to ensure that they could participate in this next phase. And what's particularly exciting about that is they don't have to go through recertification for a few more years. So it told us just how valuable this program seems to be. Our focus is on clinical quality improvement parameters, practice redesign along the lines of the patient-centered medical home, active development of clinical and non-clinical staff, as I've mentioned, and finally, asking the question, what are the essential elements of support that are needed? I really think this is an exciting project in which we've sought collaboration with the Virginia Association of Health Plans, and I have to compliment Doug Gray on helping us facilitate that over the last few months, working with them to create opportunities for data sharing and evaluation, including One Insure's incentive program for asthma and the patient-centered medical home. I should compliment the Centera Medical Group, which has a strong interest in the medical home concept, and I think forward-thinking healthcare systems like this will be seeing primary care leadership develop and really enhance the care that their systems can provide. In the spirit of partnership, we've collaborated with the American Academy of Family Physicians, the American Board of Family Medicine, and the National Heart, Lung, and Blood Institute to share knowledge and our lessons about what asthma care can be and what kind of tools physicians need to provide that. Now, the principles of the patient-centered medical home have come to represent in our initial project key factors for improvement. Colette Carver from Carillion can relate to you how To Goal helped her and her practice support their work on the patient-centered medical home and how to move that process forward, particularly in terms of a whole person focus, use of registries, understanding how to use your EMR better. Most EMRs were sold to docs as billing and coding systems, and the To Goal program has helped many of our practices with EMRs understand how to use them to provide better care and deliver on quality measures. And it was been evident in our initial program, To Goal program, that those practices who were doing the elements of the medical home were those that were achieving better improvement and in the position to sustain that. So in summary, the To Goal program and now the IMPACT program used the maintenance certification process and leveraged it to create programs that can really provide sustainable and meaningful clinical quality care. And we help them prepare for pay performance and as leaders of the healthcare system. We've also found that elements of the PCMH, or the patient-centered medical home, are really fundamental to core improvement and enhancing the likelihood that your improvements are going to be sustained. And we hope that in terms of conveying the value of this program to payers and allowing it to continue to be developed, that we can eventually do this in a system that gives us appropriate levels of support, both in the practice environment and in reimbursement. And we think we can deliver on this program, and we're looking forward to its development over the next year. Thank you.
Thank you. Everybody's heard the expression about having two people be like two peas in a pod. Well, this situation is there's 4 peas in this healthcare pod. We've heard from the provider P, we've heard from the insurance plan P, and we've heard from the patient P, or we're all the patients. While we're still new to the concept of patient-centered medical home, I've been asked to represent the purchaser P on the panel. Purchasers, employers for the most part, we're the ones who pay the majority of the costs for health care. For most employers, that cost is part of their overhead, which is ultimately built into the cost of the products that are sold and purchased in the marketplace. It doesn't matter whether that purchaser is self-insured or fully insured, whether they're for-profit, not-for-profit, or a non-profit. It doesn't matter what business model they are, what sector they're in, if they're local, if they're regional, if they're statewide, if they're national, or if they're international. The purchasers, the employers, which is a synonymous term, we generally pay the lion's share of the premiums and therefore pay the majority of the cost for health care. You're sitting there thinking, okay, well, how can that be? What's inside those premiums that are paid to the insurance companies by the employers and the employees? The cost for such things is the payment to you all, the providers, the labs, the hospitals, the drugs, the nurses, the wellness, the insurance companies' infrastructure, and their administration of claims payment. All of these costs and more are included in the premiums that are paid by the employer and the employee. So what is it that us purchasers want? Basically, we all want the same thing, and we want the same thing everywhere. Everybody wants a marriage between cost and quality. How do we get there? To be totally honest with you, I don't have any idea. But there are many employers, some of them are here, and many of them are not able to make it today, who are actively looking for solutions to this problem. The cost of providing health care for our employees is starting to bubble to a point where some very hard choices may need to be made by employers in the future. One solution we've heard about today is the patient-centered medical home. Is it going to cost us more? I guess the answer to that one is it depends. It depends on how it's implemented. When I initially heard about this, I was very skeptical. I really was skeptical. It sounded to me like a prepackaged or repackaged HMO, another form of a gatekeeper which promises a whole lot and may or may not deliver and meet expectations. The more I learned about it, and especially after I heard Dr. Anderson's discussion about how he was able to accomplish the transition and why he wanted to accomplish it, I could see the merit of this, not just for primary care physicians, but for many medical services and practices. As a public employer, Chesapeake Public Schools covers approximately 80% of the total premium for our employees. Our budget has almost $50 million in it just for health care. We have over 6,000 insurance contracts which cover over 11,000 people. It's a large portion of our budget, it's about 11%. And it is growing at double digits while our revenues are sinking at almost double digits. It's not a very pretty picture right now for the public sector. Why is patient-centered medical home interesting? There's several reasons and aspects of it that are intriguing. Using evidence-based medicine, accepting accountability for continuous improvement through voluntary engagement in performance measurement and improvement. It's sort of like a No Child Left Behind for healthcare. The use of information technology, enhanced access. There's a lot of fundamental things in here that are very attractive. One of the foundational pieces which became clearer to me when I heard Dr. Anderson's experience was the value, both quantitatively but more importantly qualitatively, of the trust that comes from the relationships, not only between the doctor and the patient, but with the team of the individuals in the practice who work in a coordinated way to help that patient in and through the healthcare maze. I'd never thought about it from that angle, and the more I did think about it, the more I recognized the truth of it. The trust is built by maximizing the time, not only the quality and the quantity, but the quantity of the time that the patient spends with the doctor. That trust can translate into not only better outcomes for the patient, who are our employees, but also lower costs, both in the short term and in the long term. Is it the only answer? I don't think so. Will it cost the purchasers more? It depends. Do we need to keep looking for solutions and talking to each other? Definitely.
I want to thank our 6 panelists, our experts on the topic, and we want to open it up. It appears that we have about 7 minutes for Q&A. If you would come to the podiums, identify yourself and the organization you're with, and address the panelist to your question. Person on the left.
I'm Dr. Wickheiser, Chief Medical Officer down at Southside Regional in Petersburg. Would I like to address maybe something that hasn't been touched, and so that I can take it back to some of our staff. In all of this conversation, one of the pieces that obviously will reflect on patient care in the near future is what we expect to be a physician shortage, especially in rural areas. And experientially, it seems plain that that'll be among primary care physicians. I'd appreciate for some of our primary care 1 and 2 physician practices from you who are in practice in an office, maybe reflecting on a question they bring to me frequently. How do I bring on a new colleague? How do I bring on or entertain a resident? How do I bring them on in a cost-effective fashion? I can't afford hardly to run my own practice. How can I bring somebody on and go through the build-up phase, cost efficiency, and gain the productivity that I have to have in 6 months so that I can pay for them?
Good question. Good question. Yeah, I think there are a number of opportunities to get help. I know we struggle with that also, and some of it's to make sure I understand your question is how you bring on new physicians in an efficient fashion. I think some of it is to do a very good job of actively promoting them, of looking for areas where you can ramp up need, things that for example, when we brought on someone, we realized that we had been down a physician, and we really were behind in a lot of preventive care that we needed to. And we made the effort of combing the charts to say who hasn't been here for 2 years for their pap smear, or who hasn't been here for their blood pressure checks, and trying to reconnect with folks. It is a real challenge, especially in ramping up some new physicians that haven't had much experience. However, I think what we can look forward to in the future through some of the initiatives that Tony's doing in his department and some of the other residencies in the state is I think we're going to have residents who are much better trained to implement this kind of model and learn efficiencies so they'll be able to hit the ground running more. But I wish I had the perfect answer to your question.
I have a little bit more to add to that. In our particular practice, we have about 50 physicians, 30 of which are probably, I would say, number-wise residents. Our faculty physicians teach the residents what they need to know. The nurses are the ones that teach them the family medical center. Although I have no idea when it comes to billing exactly how all of that works. For the most part, though, because the nurses are doing so much more now instead of just doing vital signs, they're doing more testing and more things that generate an income. We're able to afford to bring more students into the practice in order to expand and grow because we've got that revenue coming in. It's the same patients that we were seeing before, they're just getting more care, and we're getting credit for the work that we were doing before.
The only thing I would say, all primary care is in financial trouble because of difficulty in seeing enough patients to generate the income needed to run the office. As we get more efficient, which improves your financial status tremendously, then you can handle an extra short-term build-up of a new physician much easier. I think before you bring on a new physician, the finances of an office have to be improved dramatically by increasing the efficiency of those present. And then you've got the capabilities of bringing in another physician without as much pain.
Thank you. Dr. Clark?
Yes,
Question?
your talk really increased my interest in the patient-centered medical home. And what I'm wondering is, who do you see as taking a leadership role in promoting this in Virginia? And once we figured out who's going to take that leadership role, do you think that they should promote and try to request a pilot in this with either a single insurer or multiple insurance companies, so we can move this thing along and make it happen more?
It seems to me that this is already kind of coming together in that when I met Barbara at this conference last year, she helped me to get in touch with people that I learned from. We're fortunate in this state that the VAFP is actively involved in this and has set aside part of its meeting time to promote practice redesign. I mean, Peter was invited 3 years ago, and there was maybe a third of the people came to see, to hear what he had to say. And at the winter meeting, again, about half of the participants came to hear the Sinskys from Iowa talk about their team care approach. But you're right, we do have to do more demonstrations and not have just a collection of anecdotes. I'm not prepared to say in a public forum with whom I'm going to be hoping to work, but I'm intending to do that, exactly what you're talking about, over the next several months. But I'm very interested in making sure that other systems across the state, the Centeras, the Carillions, and so on, are aware of this, and I would love to be in active dialogue with the leadership of those systems to talk about trying this out in theirs. What I'm aware of is sometimes even very well integrated systems, they've got all the bells and whistles out of those 10 steps. They've got like steps 4 through 9, but they don't have team care, and they're doing a very mediocre job when it comes to documentation and coding. And they don't have an open access scheduling system. So even in systems that have the HIT in spades, there's opportunity. So that's how I look at it.
On this side, Bob?
Obviously, of actualizing, I think, Dr. Elwood, you mentioned the fact that we're trying to maximize the folks in the office to their highest level, and certainly that's where we're going to get some efficiency. I guess I get a little nervous when I hear efficiency and then patient relationships. It almost sounds, at least from a business standpoint, a little conflictual. And I wonder if you could describe to us what the patient might see in this end state new service that you're going to provide. In other words, right now we know about the 7-minute experience, and it's not all that great for the patient. How do you see that changing with this new model?
In my office, I have 2 nurse assistants who work with me all day, and their primary responsibility is to work with me. For our regular routine follow-up patients, your diabetic, cholesterol, hypertension, we see 4 patients an hour. So that means I have 15 minutes per patient in that hour, and then 2 nurses have a half an hour each. Each nurse will see 2 patients in that hour. So the nurse is in there half an hour, I'm in there 15 minutes. So the patient sees at least 20 to 30 minutes of medical contact. My 15 minutes in there is I'm spending 100% of that time dealing with their medical issues, old problems, new symptoms, making sure the preventive care, or talking to them about it once the nurse gives me the information, so forth. So in a sense, I couldn't do that at all under the traditional model. If I had a 15-minute appointment, I had to spend at least 8 or 9 or 10 minutes doing ancillary things like documentation, like running down prescriptions, like explaining how this test is going to be done. Now the nurse does that. So where I might have spent in a 15-minute visit 5 minutes on the patient's medical needs, which is just unheard of in today's needs of patients as we get older and then all the options we have for treatment. Now I have 15 minutes and sometimes 20 minutes if I need it to spend focused on the patient's needs. So the patient, when they come into the office, they'll see a 20 to 30 minute involvement with the nurse and 10 to 20 involvement with me.
The other thing about that is that if you have, for example, for those of you who have patients who have access to email, a more efficient patient portal will allow us to say, if you have asthma, let me know what, report in what your child's attack score is or HTT score is in a week, and they'll do that. Now, for the people who don't have EMRs, they'll get my call from one of my nurses, because my nurses won't be hung up on the phone anymore. They'll actually have more time to do the personalized phone call follow-up, and yet my patients who can use the efficiencies of electronic patient portal will be able to use those.
Thank you. We have about a minute left, so this is the last question.
I have more of a comment than a question. I'm Colette Carver. I'm the family nurse practitioner from Curlian Clinic, and we work with Dr. Allward, and we work with Tagol, and that helped to ramp us up to do the patient-centered medical home pilot. So I get to head up the pilot at our office, so we have that going on right now. And another thing that's happening at Curlian, and if anyone wants to talk to me, I'd be happy to talk to them, is that what Tony Kuzel is talking about, the 2 nurse to 1 physician and increasing revenue and the Sinsky model and all that, that's another thing that we're actually piloting as well. So we're looking at the 2 pieces and then comparing, and it's very exciting, but it's all about engaging your team, and what Kurt has said is sustainability. So I have the pleasure to work with Dr. Mark Watts, who's the president of Virginia County Family Physicians, as my partner. So we together are, actually he's been in Washington all week, and it's been very difficult to see his patients, but he's out there also banging the drum for the people who aren't working for Curlian, who have to implement this and have to figure it out without somebody that they can take away from the patients. So we're trying to be sensitive to all that when we get to spread it, but he's banging the drum. And if anyone wants to talk to me about the minutia of doing it, it's fun, but we're doing it now.
Thank you. Our time is up. I want to thank you for sticking out through the end of the day. I want to thank our panelists. You can imagine how challenging it is to talk about this subject and have these 6 experts and give them 4 minutes each. So I really appreciate them. They all have a passion for the concept of improving primary care. And again, you'll hear more about the topic, and we're very interested in the coalition collaborating on this initiative. Thank you.